Hi everyone, good morning. Am I audible and visible? Hello. All right, good morning everybody. So, am I audible and visible? So, happy Diwali to all of you in advance. And I know we've had a little last few days when we couldn't have the classes only because it's Diwali time. So, in and of certain things keep coming up. But of course, I always thought I will be covering national health programs, which is one of the most important things for your INICT as well. All right, so good morning. So it's not a very big session. Again, I will just give out a couple of MCQs that you can have a look, and then guys, we will be having our LRR on 30th of October. Your LRR for INICT is planned on 30th of October. LRR for INICT is on 30th of October. Okay, chalo. So yeah, happy Diwali also to everyone in advance. Today, definitely study. Tomorrow, do enjoy, spend time with your friends and family. That is one of the most important things in life, guys. Spending quality time with your parents. Okay. So later, we really, when we grow up and when we are away from them, we really realize that what good times it was when we were at home with the parents. So do spend time with them if possible. If you're visiting them, just be with them, right? Okay, so look at the first question now. False about epidemiology of JE. I'm not going to take too much of your time, 40-45 minutes on the clock. So can you answer this? False about epidemiology of Japanese encephalitis is anybody? Signs and symptoms seen in pig. Man is an incidental host. Horse shows signs and symptoms endemic in 21 states in India. What are you going to mark? Happy Diwali, Nasya. Happy Diwali, everyone, in fact. All right. And during these festive times, somehow we're not very, we feel like, chalo, 2 दिन पढ़ ले, like, थोड़ा सा कम भी पढ़ लोगे, it's okay. That's okay. All right. But once you're back, from these times you should this thing, and even if you're not at home, guys, please don't feel bad. Remember, you just need some quiet time. Just pray, sit with them, then after praying watch something. If you've not gone home, whatever to do, whatever reason, it's just this time. Next time will definitely be with your family. Okay, so what is your answer? कोई बात नहीं रजत, कम हो रही है, दैट्स ओके, थोड़ा चलता है। एक बार जब ये थोड़ा सा वो हो जाएगा, उसके बाद यू हैव टू put your everything in the preparation, right? All right, so what is this? Very good. Signs and symptoms are seen in pig. No, we all know pig is the amplifier host. It is the amplifier host. It doesn't show any signs and symptoms. No signs and symptoms. Man is the accidental or incidental host. Definitely no man-to-man transmission. Horse is the only animal which shows signs and symptoms. It's endemic in 21 states in India. Okay? And you all remember this life cycle, guys. So here you have the water bird, or this is known as the ardite birds, guys. Ardite birds. These ardite birds are the accidental or incident. These are the not the these are the natural reservoir. Okay, these ardite birds are the natural reservoir. They host the virus. They are the natural reservoir. Then what is the vector in this case? The vector in this case, everybody knows, is Culex, right? Japanese encephalitis, Culex tritynorhynchus or Culex vishnui. Man is the accidental or tenant host, and of course this is the pig, which is the amplifier host. Okay? All right. Let's go to the next MCQ. A 10-year-old child with unprovoked dog bite comes to you. Appropriate action is, what are you doing to do? What's your answer, everyone? A 10-year-old child with unprovoked dog bite comes to you. Appropriate action is withhold vaccine and observe dog for 10 days. Give cell culture derived vaccine. No further action is necessary. Kill the dog and send for brain biopsy. Now, see, why did I give you this question? Because this is a term which is given in our textbooks also. Even if it's an unprovoked dog bite, guys, it's not like we don't have to do anything. Dog bite is a dog bite. You immediately have to figure out the category. Now, here it is a bite, so it is category 3. Okay, it is category 3. Then when you talk about category 3 wound, what is the other thing? You wash the wound, you give the vaccine, and you also give rabies human immunoglobulin. So here withhold vaccine and observe for 10 days? No, not at all. Give cell culture derived vaccine. Now suppose next time they give you a question that the dog remains healthy on the 10th day. What do we do? Guys, even if the dog, suppose somehow we were able to catch hold of the dog, or it was a pet dog or whatever, we were able to catch hold of the dog and the dog remains healthy at the end of the 10 days, still you will continue with the vaccination schedule. Please don't stop it. We all know rabies is 100% fatal, so we have to give it. All right. And what is the schedule that National Rabies Control Program prefers? Anybody in the comment section? National Rabies Control Program recommends which regimen to control rabies? Anybody in the comment section? National Rabies Control Program recommends which regimen to control rabies? Everybody. So National Rabies Control Program recommends updated Thai Red Cross regimen. Updated Thai Red Cross regimen. Now from here you can very well make out I. So I say it is being it is being practiced in India. All right, I say India, and this D is what? Intradermal regimen, ID regimen. Now, what is the dose for ID regimen? The dose for ID regimen is 0.5 ml. Okay, 0.5, sorry, 0.1 ml. Intradermal 0.1 ml. Now, as you can see, Thai has how many letters? So as you can see, Thai has 4 letters. So how many visits are going to make to the doctor or the clinic? 4 visits, which is on day 0, 3, 7, 28 and 22nd day. And it's going to be given on two sides. Two sides simultaneously. For children, it's the thigh. For the adults, it's the deltoid. Clear? So this you should remember. Also, they ask question on human immunoglobulin. Human immunoglobulin, the dose for this is 20 international unit per kg body weight, and most of the immunoglobulin is given around the wound site. Am I clear? Everybody, will you remember this? ठीक है. So unprovoked dog bite, it's not like you don't have to give. Remember, if the dog stays healthy, then also continue with the vaccination schedule. If somebody has been bit by a pet dog, then also you have to give the vaccination schedule. ठीक है. Okay, vaccinated dog. I mean, somebody got bit by a vaccinated dog. Still, we have to continue with the schedule. Okay, what's the answer to this? ASBILS, which is an ASHA-based surveillance project, is initiated for which of the following diseases? Yes, your answer. ASBILS, which is an ASHA-based surveillance project, has been initiated for which of the following diseases? Leprosy, tuberculosis, leishmaniasis, STD. What's your answer, guys? ASHA-based surveillance. I've not got a single answer. Try to give one. Very good. No, not for STDs. What's the answer? This term particularly has been given for leprosy. Okay, ASHA-based surveillance project. So this term has particularly been given for which disease? Leprosy. ASHA, if she is able to detect, okay, ASHA-based surveillance for leprosy. That means she's particularly going out to the fields and looking for leprosy cases. And if she is able to detect, if Asha can detect a case, if she is able to detect a case without disability, okay, she's going to get rupees 250. And if she is able to detect a case, with disability, all right, with disability, she will get rupees 200. If she is able to detect a case without disability, 250. If she is able to detect a case with disability, rupees 200. Okay. Moving ahead. Most efficient anti-larval measures to prevent urban malaria is anybody? A very important question, a good question, I would say. Anti-larval measures. What are the anti-larval measures? Think and mark. Most efficient anti-larval measures. So anti-larval measures तीन होते हैं. ECB. E is environmental control. E is environmental control. ठीक है, to control larvae. C is chemical control, and B is your biological control. B is your biological control. Now, what are the chemicals that we spray, guys? So the chemicals that we spray is abate and also Paris green. But in the program to control larva, we prefer abate now. Environmental is permanent method. It yields permanent results. Environmental control yields permanent results. Listen to it very carefully. Permanent results. Permanent results means source reduction. Environmental control focuses on source reduction. ठीक है, like leveling the ground, filling of drains and ditches, all these are environmental controls. All these are methods of environmental control. But which out of them is more important for urban malaria, guys? So in urban malaria, to control urban malaria, anti-larval measures, over here the important one is cover overhead tanks properly. Why? Because of anopheles, guys. Covering overhead tanks because of anopheles. Okay, so you can have a look over here. Overhead tank anopheles, drainage or sewage is Culex, filling cesspools and ditches is Culex, covering pits of course is to control housefly. This one's important. Urban malaria, us. What lives with us, guys? I've given you the mnemonic also. Urban malaria, what is very common? Us. Something which is living with us, which is Anopheles stephensi. Okay, Anopheles stephensi. Therefore, in urban malaria, we need to control Anopheles, which is more prevalent in overhead tanks. Clear? Give me a thumbs up, all those who are there. Everybody got this question. So, to control urban malaria, it is cover overhead tanks properly. Okay, next question. A pregnant woman in her third trimester has fever, was diagnosed as a case of falciparum malaria. What drug is recommended? Again, one of the very important topics for your INICET, NEET, PG, FMG, any exam is treatment of malaria. Okay, so I'll just give you a very basic listing of this, that what are you going to do over here. So look over here, it is falciparum malaria and the woman is in the third trimester. That means she is pregnant. So whenever it is Plasmodium falciparum, in the first trimester, what do we give? Quinine. Okay, but if she is in the second or third trimester, guys, if the woman is in the second or third trimester, have a look HY over here. I will be telling you, okay, the regimens. If she is in the second or third trimester, we are going to give ACT, artemisinin combination therapy. That you have to divide into other states and you have to divide into northeastern states. Okay, other states and northeastern states. So if you have other states is ACT, SP, sulfadoxine, pyrimethamine. Northeastern states is ACT, LM. Artemether lumefantrine. Now, if she was not pregnant, we would have added primer-queen also. But remember, primer-queen, everyone. Primer-queen, okay? Primer-queen. Contraindicated in pregnancy. We are not going to give primer-queen in pregnancy. So, here she is in the third trimester. What are we going to do? ACT only. But suppose in the exam they give you overall drug of choice for falciparum in pregnancy. They don't mention trimesters. Did you understand the question? They write, suppose they write overall drug of choice for Plasmodium falciparum in pregnancy. Okay, irrespective of the trimesters. They have not mentioned the trimesters. Your answer is ACT. If they ask you overall drug of choice, they have not mentioned trimesters. What does your answer become, everybody? ACT, not quinine, ACT. Okay, if they don't mention trimesters, it is always ACT. Give me a thumbs up. Got this question? Okay. All right. Next, let's see if you can answer this. A patient on heart regimen presents with complaint of fever and expectorant cough for 2 weeks. What is the first investigation of choice? Sputum microscopy, CB-NAT, sputum microscopy, chest X-ray, tuberculin test. What are you going to answer here, guys? Heart regimen means which regimen are we talking about? If you talk about heart regimen, the heart regimen means ART, highly active ART regimen, which is for HIV. That means the person is a case of HIV, the person is living with HIV. Now, most common opportunistic infection among people living with HIV in India is TB, right? Most common opportunistic infection among people living with India, among people living with HIV in India is TB. And what is my first investigation of choice? It is CBNAT. CBNAT is the investigation of choice to detect TB in a person living with HIV. What happens? Look what I'm teaching you. Person is living with HIV. You are going to do a CBNAT, guys. Now, what is going to happen? Two things can happen. The person is TB positive. The person is TB negative. Now, if the person is TB positive, everybody, it is HIV TB co-infection. So what are you going to start first? Are you going to give ATT or ART? So we will always start ATT first. Start ATT first, and then 2 weeks, then 2 weeks later, 2 weeks later we can start ART. It usually takes 2 to 6 weeks to start ART in a person. Start ART. Why do we start ATT first? Start ATT first because it prevents something which is known as immune reconstitution syndrome. It prevents something known as immune reconstitution syndrome. Okay, it's going to prevent this syndrome. And in case the person is TB negative, this over here, guys, is preventive TB therapy. We don't want him or her to develop TB. So now the choice is 3 months isoniazid, 3 months isoniazid plus rifampicin, which is given weekly, plus rifampicin given weekly. Okay, that you should remember in your exams. Investigation of choice for a person living with HIV to detect TB, everybody, is CBNAT. Okay, that you should not forget. Clear? Can we go to the next question? All these are MCQs. This is a PYQ. This is a PYQ. This is a question. So 3 questions we've covered from one listing. Okay, what is the treatment regimen for possibacillary leprosy? Just wanted to discuss the update, which is difference between possibacillary and multibacillary. What's the answer? Possibacillary. Now see, the classification is possibacillary, and let me write it over here. The classification is PBL and MBL, and the classification is done on the basis of skin lesions, guys, on the basis of skin lesions, on the basis of nerve involvement, on the basis of nerve involvement. Also, it is done on the basis of skin smear examination. Skin smear examination. All right. These are the 3 things. Now, for what is this is the updated guideline. Now, what about possibacillary leprosy? Okay, say it is 1 to 5 lesions. If the person has 1 to 5 lesions, to call it as a multibacillary, more than 5 lesions. To in possibacillary leprosy, no nerve involvement, no nerve involvement. In multibacillary leprosy, more than equal to 1 nerve involvement. Okay, more than equal to 1 nerve involvement. Clear? No nerve in nerve possibacillary. And slit skin smear examination, negative at all sites. This is negative at all sites. But if you talk about multibacillary leprosy, guys, it is positive. Remember, it is positive at 1 or more sites. 1 or more sites. It is positive. And to start MDT, everybody, to start MDT. Okay, to start MDT, guys, what is very, very important? Remember, to start MDT, we don't have to wait for skin smear examination result. You can start MDT based on these 2. Okay, you can start MDT based on skin lesion involvement as well as nerve involvement. So over here for possibacillary and multibacillary, It is 3-drug treatment regimen. The treatment for possibacillary 3-drug, which is from 6 to 9 months, and for multibacillary it is 12 to 18 months. Okay, 12 to 18 months. So what is the answer over here? Like you said, 3-drug for 6 months. Now we have 3 drugs. And what are those 3 drugs, guys? The 3 drugs that we use are dapsone, rifampicin, clofazimine. Rifampicin, clofazimine. All right. And over here, please remember, rifampicin comes as monthly supervised dose. Rifampicin is available as monthly supervised doses. Okay, only as monthly supervised doses. Clear? With one question you understood. Asha is making is trying to look for cases of leprosy, and of course you should know the treatment, this classification. All right, let's go to the next question. A malarial survey is conducted in 50 villages having 1 lakh population. Out of 20,000 slides examined, 500 turned out to be malaria positive. What is API? What was the formula for annual parasite incidence? This can come in the exam, guys, particularly INICET. They kind of love it. Annual parasite incidence. So annual parasite incidence is, you will have multiplier 1000 out of the total population under surveillance. Okay, population under surveillance, out of the total population under surveillance, how many are positive? Okay, 1 lakh population, how many turned out to be malaria positive? So total malaria positive cases. So over here, how many turned out to be malaria positive? Now look over here, you have so many values: 50 villages, 1 lakh population, 20,000 slides examined, 500 turned out to be positive. So what are the things that you're going to use, guys? Please don't worry about these slides, you don't need it. The total population is 1 lakh. Okay, out of that, how many, out of the slides examined, how many were positive? So we all know 500, and this one over here is 1000. Okay, this one over here is 1000. So like most of you have given me the answer 5. Okay, 5 per 1000. So answer is 5. Did you understand? Everybody, did you understand? Why have you got, why have some of you written 0.4, guys? You don't have to take the slides examined, guys. For API, you always have to see what is the total population. Out of that, how many have turned out to be positive? 500. Is that clear? And API is a measure of, burden of malaria. API is a measure of burden of malaria, and the elimination strategies, guys, are based on API. Elimination strategies that we have are based on annual parasite incidence. Okay? Okay, one more thing, everybody, from here that you should remember. Suppose I gave you to calculate ABER, annual blood examination rate. In that case, you would have taken total slides examined, Okay, out of that, how many are positive for MP? And we would have multiplied it with 100. So what is the total slides examined over here? 20,000. Out of that, how many turned out to be positive? Yeah, Preeti, I will tell you that. Just finish. Let me finish. I'll tell you today only. Just give me one moment here. Okay, into 100. So over here, if you see, then you will be calculating and you will be seeing what it comes out to be. Okay. In this case, you will be needing your slide examination rate. Otherwise, you won't be actually leading. 5 by 2 ho jata. So 2 twos are 4, 2.5 some percent it would have come out to be. Am I clear? Did you understand this question or not, guys? And what is slide? If somebody asks you what is Sorry, one second, everybody. This we are calculating slide positive rate. Okay, this we are calculating slide positive rate. For slide positive rate, out of the total slides examined, how many are positive? So this is slide positive rate. But if I ask you ABER, if I ask you ABER, suppose I gave you to calculate ABER, that is population under surveillance. So what is the population under surveillance? 1 lakh. Out of that, how many slides have been examined? 20,000 into 100. Is it clear? If I had given you ABER, in that case, your answer would have been 20%. So in this one numerical, we have done a couple of things. First, API. API out of the population under surveillance, total positive cases. What is ABER? Population under surveillance. Out of that, how many slides examined? And the third one, out of the total slides examined, how many positive? This one. So that becomes your answer. Clear, everybody? Did you get this question? Give me a thumbs up. Okay. All right. What's the answer to this? Quickly tell me the answer to this. 5-year-old boy received a full course of rabies vaccine in December 2018. In November 2019, his fully vaccinated pet dog bit him on the toe, causing bleeding. What is the recommended treatment? Good morning. So what is your answer over here? Anybody? Now look over here. This, when we talk about prophylaxis of rabies, it could be post-exposure, pre-exposure, re-exposure. This is a case of re-exposure prophylaxis. Now just wanted to clear certain confusions over here. In case of a re-exposure prophylaxis, you just have to look at the time interval. Okay, if it is within 3 months, if it is within 3 months, or if it is beyond 3 months, within 3 months or beyond 3 months. Okay, now if it is within 3 months, guys, we will just wash the wound, nothing else. Wash wound, no vaccine, no immunoglobulin, provided the person was vaccinated completely in the last bite as the required number of doses. Beyond 3 months, what we have to do? Now, if you look at re has how many letters? Re has 2 letters. So how many visits we are going to make to the doctor or the clinic? 2 visits. And when are we going to make these 2 visits, guys? Day 0 and day 3. Day 0 is the first day of the vaccine intake, or not the first day of the dog bite. Okay, it's the first day of vaccine intake. And the regimen here could be IM or ID. That's immaterial. But what I'm trying to stress over here, you just have to look at these gap, guys. And this is lifelong. There's no change over here. Beyond 3 months will remain forever. And provided only if he had been properly vaccinated according to the required doses in the previous bite. Yes, and immunoglobulin given once in life is not repeated. Immunoglobulin given once in life, human immunoglobulin for rabies given once in life, not repeated. Life, not repeated. Also, immunoglobulin can be given up to 7 days from day 0. Clear? And most of the immunoglobulin is given around wound site. Most of the immunoglobulin is given around wound site. So here it was re-exposure, as you can see. So what is the correct answer? 2 doses on day 0 and 3. Some of the students keep getting confused regarding this thing. It's beyond 3 months, only 2 doses life. Okay? Chalo, let's move to the next question. What's your answer over here? Which is not an essential indicator under National Leprosy Eradication Program. Now, this is very important MCQ for INICET, guys. Indicators. We are asking you not an essential indicators. I only want you to know for leprosy a couple of essential indicators. So annual new case detection rate per 10 lakh population per year is an essential indicator. Prevalence rate is an essential indicator. We know that we have to keep the prevalence below less than like prevalence per 10,000 population for leprosy should be below 1. Treatment completion rate is also, but this one, guys, new cases diagnosed correctly is not. Look over here. The essential indicators are ANCDR per 1 lakh population, which should be less than 10 cases. Rate of new cases with grade 2 disabilities per 10 lakh population. treatment completion rate, and prevalence rate. These are essential indicators. Here it was proportion of new cases diagnosed correctly is not a very essential indicator. It is annual new case detection rate, which is important per 10 lakh population. Just saying new case doesn't make sense. Are you understanding? And that too, new cases we always check for grade 2 disability, which is an essential indicator. Got it? So I think Exportant got it correct. Yuvaraj got it correct. Okay, everybody understood this. For leprosy, this one's important. Don't mess it up. I've taken leprosy because more chances of leprosy coming up right from the logo to Sapna. I hope you all remember Sapna. We've discussed n number of times. What is the answer to this? Chemoprophylaxis of leprosy should be given to all contacts except. Now, prophylaxis means primary level prevention. We have somebody at home who is a risk factor for us, can be or in the neighborhood, 3 houses on the right, 3 houses on the left, could be suffering from leprosy. So to stay protected, we have to take a drug. So what is the drug? It is rifampicin, everyone. I hope you remember, and it is not given to age more than 1 year. It has to be given to more than 2 years. Household contacts, definitely living with a leprosy patient for more than 6 months. Yes. Social contact of 20 hours per week for 3 months. That again, this could be asked separately also as an MCQ. So you can just go through this whenever you have time. Prophylaxis is given to close household contacts more than 2 years old. Close contact means more than 20 hours per week. Neighbors within a 7500 meter radius. Contraindicated in pregnancy, and this is the dose. Of course, I always say once you should definitely go through your pharmacology for mechanism of action, side effects, and the doses. Okay, next question. A person has received complete immunization against tetanus 10 years ago. Now he presents with a clean wound without any laceration from an injury which is sustained 3 hours ago. He should be given. So what's your answer over here? He should be given. What is your answer over here? Now again, I've taught you this many times. When it comes to tetanus, figure out clean or unclean wound. In an unclean wound, only we add immunoglobulin. So these are the categories that you should revise and go for your INICET. Category A is full immunization within 5 years. Category B is full immunization more than 5 years but less than 10 years. Category C, full immunization more than 10 years ago. Category D, unknown, or we have not known, or we have never taken immunization. Point to be noted, you will divide the wounds into clean and unclean, guys. And remember, immunoglobulin, if you see, is only added in unclean wounds. So that will also help you rule out the option. If full immunization within 5 years, clean, unclean, only wound care, only wound care. Category B for clean, unclean wound, more than 5 years ago, but within 10 years, wound care plus TT single dose. I have repeated it a number of times. In trauma case, it is always TT. In NIS, it is TT. So wound care, TT single dose. But if it was full immunization more than 10 years ago, clean wound again, single dose only. Here you will again add an immunoglobulin. And if the status is unknown or never taken, then wound care plus TT complete course. But in unclean wound, we are again going to add an immunoglobulin. Okay, this question is important. Please don't mess it up. Remember, tetanus immunoglobulin is only given for unclean wounds. So over here, this person had received immunization 10 years ago. So that puts him under category C. But now he's presenting with a clean wound. So clean wound category C, you don't have to add any immunoglobulin. You will just give a single dose of TT. Clear? And tetanus is one such disease where soil is both source and reservoir of infection. Soil is the source and reservoir of infection. Clear? Everyone, tetanus management. Don't mess it up. All right, going to the next one. Which of the following is excluded from the STEPS approach of WHO? Anybody? STEPS approach is an important concept which was given by WHO. It is something which is not meant for treatment or management of NCDs. No, it's just surveillance of risk factors of NCDs. We're doing a surveillance of risk factors of NCDs. So step 1, step 2, step 3. What is your answer over here? So come on, quickly give your answers. So the correct answer over here is, you all know, let's have a look at the steps approach. See, this is step 1 where we're getting a questionnaire fill. So in questionnaire, we take information like lifestyle, behavioral, psychological information. Lifestyle, behavioral, psychological information. Okay, psychological information. Like what are your personal habits, smoking, diet, everything, social demographic profile, everything. Physical measurement in step 2. So here we are going to take anthropometry. Anthropometry means we're going to take height, weight. Okay, we are going to calculate BMI, blood pressure, all of those. Biochemical, we are going to do a lab investigation, all the blood measures. Okay, like blood cholesterol, blood glucose, lipid, all of those things. So here it is behavioral assessment. We will do it in the questionnaire. We will do a psychological assessment. We will do a physical assessment. But therapeutic, it has nothing to do with therapeutic assessment, guys. Okay, it has nothing to do with therapeutic assessment. Okay. Okay, give me the answer to this. I just wanted to discuss one thing for TB and the updated regimen which has come. A TB patient whose biological specimen is resistant to more than one first-line anti-TB drug other than both isoniazid and rifampicin is classified as. What is your answer here? So resistant to more than one first line drug, but not rifampicin and isoniazid. So what is your answer, guys? Your answer definitely is polydrug resistant. Okay, mono drug means resistant to any first line drug, resistant to any first line drug, except rifampicin. Because if I am resistant to rifampicin, I will be called as rifampicin resistant TB. Okay? Polydrug means this one, resistant to more than one first line drug, but not isoniazid rifampicin. Because if we are isoniazid rifampicin, it is multi-drug. ठीक है. And what is, guys, pre-XDR? Pre-XDR is MDR plus resistant to any fluoroquinolone. आ जाओ, फिर ले जाना. Okay. So if you talk about pre-drug resistant means MDR plus resistant to any fluoroquinolone. Let me write it here. Okay, pre-XDR. Pre-XDR means MDR plus resistant to any fluoroquinolone. Resistant to any fluoroquinolone. Okay, resistant to any fluoroquinolone. Any fluoroquinolone except levo and moxie. ठीक है, except levo and moxifloxacin. But if we talk about XDR, everybody, so XDR is definitely pre-XDR plus resistant to any group A drug. Resistant to any group A drugs. Now, what are the group A drugs? The group A drugs can be bedaquiline. The group A drugs is bedaquiline. The group A drugs is linezolid. And the group A drugs, you can also include levo and moxie. Am I clear, everyone? Will you remember these points? Definitions definitely can come. Okay? And one more thing over here you have to remember. What is the new regimen for MDR TB, guys? It is 6 months of D-PAL-M regimen. Bedaquiline, pretominid, linezolid, moxifloxacin. Okay? Chalo. Just a couple of more questions, guys. What's the answer to this? NACO recommends sentinel surveillance for HIV. All are aims of sentinel surveillance except. What do you have to answer over here? Okay, so can you quickly tell me the answer to this? NACO recommends sentinel surveillance for HIV. All are aims of sentinel surveillance except. जी हाँ, पितवाली बोलो.
Happy Diwali.
Nico, happy Diwali.
Happy Diwali.
Loudly, happy Diwali.
Hello. Hello.
अच्छा ठीक है चलो so what is the answer to this one guys NACO recommends so sentinel surveillance is particularly for H हाँ उनको बोलो
उनका बोलो अरे तेरे
बस चलो Okay, so NACO recommends sentinel surveillance for HIV. Now, sentinel surveillance, all our aims of sentinel surveillance except estimate total infection in the community, total cases in the hospital, estimation of trend of disease, classification of district. So, we all know HIV sentinel surveillance, it's not meant for total cases of HIV. It's not for estimating total cases of HIV. ठीक है उसके लिए नहीं होता है आई मीन टोटल केसेस इन द हॉस्पिटल सेंटिनल सर्वेलेंस मीन्स नाउ सी फॉर HIV we can't go house to house looking for cases. For HIV, we can't do a reporting from the hospital. So what we are going to do, we have made certain ANC clinics. Okay, we have used certain ANC clinics, guys, where we are going to look at the prevalence of HIV once every 2 years. Okay, once every 2 years we look at the prevalence of HIV over there and extrapolate it to general population. So ANC females used as proxy indicators. ANC female used as proxy indicators for HIV prevalence. ANC female are you? Bye.
Bye.
Okay. ANC females are used as proxy indicators for HIV prevalence in the community. ANC prevalence is used, females are used as proxy indicators for HIV prevalence. Clear? So why are we doing a sentinel surveillance? To know about the prevalence of HIV, to estimate the trend of diseases, to classify the districts. We don't use it for total cases in the hospitals. And one more question, guys. STD clinics are no longer used for sentinel surveillance. एक क्वेश्चन आया था बहुत पहले एम्स पेपर में sentinel surveillance में do we use STD clinics? So remember STD clinics are no longer used. STD clinics no longer used for sentinel surveillance. No longer used for sentinel surveillance. To conduct sentinel surveillance, our most important group is ANC females. ठीक है everybody, you can also do it in commercial sex workers, injectable drug users, but this one's not used. Happy Diwali everybody. All right, so I think that's it for today. Do I have one more question? Yeah, I have one more last question. Anybody for this one? A baby is born to an HIV positive mother. Which of the following statement is true about the management of a baby born to an HIV positive mother? I just wanted to share a couple of lines over here. Although I will be talking about this in a compiled form in our LRR, which is going to be held on the 30th of October. So now see guys, a couple of things for any woman who is HIV positive. Any pregnant female, okay, who is HIV positive. So what are we going to put her on? We are going to put her on ART. Okay, irrespective of gestation, put her on ART. Now what do you do for a baby who's born to an HIV positive woman? Okay, let me first teach you this one. Look over here, guys. Low risk infant. Who is a low risk infant? Born to mothers with a low viral load detected after 32 weeks of pregnancy till delivery. Wait, I'm going to start this again. What are we studying over here in this particular slide? This is one of the most important slides for exams. It is PPTCT. PPTCT, prevention of parent to child transmission of HIV. Almost PPTCT contributes 5% of total HIV cases. Total HIV cases. And efficiency of this route, okay, the risk of transmission of this route is 30% without treatment. All right, 30% without treatment. But if you talk about treatment, with treatment, it is going to decrease. It goes below decrease. It decreases, like it goes below 1%. It becomes less than 1%. Okay. Now, first situation, you have to see whether the baby is a low risk or high risk infant. Who are low risk infants? Born to mothers with a low viral load, which is detected after 32 weeks of pregnancy till delivery. That means the mother's viral load is less, which is detected after 32 weeks. Or we could say the mother is on ART, she is on ART, or she has taken ART at least for more than 4 weeks, or ART for more than 4 weeks. That is the low risk infant. So for any low risk infant, give syrup nevirapine or zidovudine, but we prefer syrup nevirapine irrespective of the type of feeding from birth to 6 weeks. The baby can have exclusive breastfeeding, replacement feeding. No mixing of feedings allowed in a HIV positive baby. That's very important. So whether the baby is on exclusive breast milk or replacement feeding, low risk infant, syrup nevirapine has to be given from birth to 6 weeks. But if it's a high risk infant, who is a high risk infant? Born to HIV positive mothers who are not on ART, or they took ART but less than 4 weeks duration, with viral load not estimated beyond 32 weeks, viral load not suppressed after 32 weeks, or diagnosed with HIV within 6 weeks of delivery. All of this is diagnosed with HIV within 6 weeks. All of this put into high risk. In that, we have to add nevirapine as well as zidovudine. If the baby is on exclusive replacement feed, birth to 6 weeks. But if the baby is on exclusive breastfeeding, birth till 12 weeks. This is very important slide of the day, guys. Okay. Prevention of parent to child transmission. To figure out low risk infant criteria, high risk infant criteria, and you have to figure out what drugs have to be given for what weeks. And remember, mixed feed kabhi allowed nahi hota hai. No mixing of feeding allowed. Clear? So now let us see the question, everyone. If replacement feeding, which of the following is true? Okay, to a HIV. If replacement feeding, the neonate should be tested for HIV. If negative, ART not required, it's nothing like that. Okay, if the baby is on replacement feeding, the neonate has to be tested for HIV, and we have to keep testing it at regular intervals. After like 18 months, we take that decision. In exclusive breastfeeding, give nevirapine for 6 months only when the baby is positive. No. In exclusive breastfeeding, we are giving nevirapine. If you see over here, exclusive breastfeeding, we are giving nevirapine as well as this thing, irrespective of the feeding for 6 weeks, even if the baby is HIV negative, not just in case of HIV positive. If exclusive replacement feed, give nevirapine for 6 weeks, even if the baby is negative. Okay? So I think I missed out an option. If exclusive breastfeeding, give nevirapine for 6 weeks, even if the baby is negative. I'm so sorry. I think we missed out one option. Of course, if exclusive replacement feeding, you will give for 6 weeks, even if the baby is negative. So this becomes your right answer. Okay, remember guys, a couple of things over here. Don't mix feed, no bottle feeding allowed. And if the baby is a low risk infant, syrup nevirapine for 6 weeks, irrespective of the type of feeding. High risk infant, nevi plus zido. If it is breastfeeding, then for 12 weeks, replacement feed, then for 6 weeks. Clear, everyone? Okay. Last STI color kits. I hope you remember. Now we have 8 kits, guys. We have 8 kits with us. The first kit is gray in color, which is a very dull color. It has urethral discharge and cervical discharge, UDCD. Urethral discharge, cervical discharge. Earlier it had anorectal discharge also, but now that's in kit 8. So over here, gray, we can give azithro, cefixime, all of that. Kit 1. Second is ladies first, which is green color, vaginitis, secnidazole, fluconazole. Third is no discharge, ulcer. But the good thing is it is non-herpetic ulcer. It's not herpes, and penicillin is acting on it. So the color is white. Okay, so this one is penicillin. This one is penicillin. Fourth one, guys, non-herpetic ulcer. But again, a little bit of problem. Penicillin is allergic. So the color is little darker blue. Allergic to penicillin. Okay, allergy to penicillin. After that, we have danger. Danger is always red color. Herpes, herpetic ulcer. Okay, so the danger is always red. So that is what? Acyclovir. Then kit 6. 6 is what? Yellow. Yellow means lower abdominal pain. Give cephalosporin. Lower abdominal pain. Kit 7, of course, you all know. I'll write over here. Kit 7, you know, black, which is bubo. Okay, and kit 8 is the latest one, which is brown kit, and it is separately having anorectal discharge, ARD. So you can match this. LL yellow, urethral first one, UDCD gray. Okay, UCG, UDCD gray. Then vaginal discharge green, and this one is this thing. So what is your answer? A4, B1, C3 and D2. So this one is your correct answer. Okay? So that's a big thank you from my side, everyone. Now I know it's festival time. Of course, it becomes a little difficult for you guys also to concentrate. But remember, even if you've not been able to go home, don't lose heart and hope, guys. Just relax, get yourself some time to figure out, some time to process things. How's everything going? And remember, nothing is more important than you. Once a couple of 1 or 2 days later, bounce back with the same determination, even better. Okay, and remember, it's a phase of life. If due to some reason you're not at home this time, you will definitely be home next time. And just think about the good things in life. Don't lose heart and hope. Okay, yeah, 1,100. So remember one thing, guys, any formula which is like prevalence, case fatality rate, secondary attack rate. ठीक है, over here we have multiplier 100. Multiplier 100. These are the things that you have to know. Preeti, MMR is the only place where multiplier is 1 lakh. Okay, rest everywhere, okay, whether it is all the neonatal mortalities, IMR, under 5, all child health formulas, then perinatal, every other formula, the multiplier is 1,000. Also you have to know incidence, the multiplier is 1,000. Okay, okay, so now all right, so now of course I will meet you again. The big day for that is LRR INICET 30th October. Join me then, everybody. 12 p.m. on Prep Ladder YouTube. It's not on this this thing. 11 a.m. or 12 p.m. we will see that. But all of you, happy Diwali. God bless you all. Bye bye. Take care. Have a very good good week. Okay. Thank you so much.